Hola, muy buenos días, tengan todos ustedes. Bienvenidos a nuestro último día de nuestra 24ª Reunión Nacional de Morfología. Bienvenido, doctor Marco Corchaque. Muchísimas gracias por aceptar la invitación a estar con nosotros. Es para nosotros un honor contar con su presencia. Les recuerdo a todos los asistentes que tenemos una opción en la parte inferior de la pantalla que dice traducción o interpretación. Ustedes deben seleccionar el idioma en el que quieren escuchar esta conferencia magistral. Sin más, recordemos que la gran mayoría de nuestros invitados están a través de redes sociales, ¿sí? A través de YouTube y a través de Facebook, por lo cual les pedimos que si tienen preguntas nos las escriban ya sea en las redes sociales o a través del chat que está aquí. Y bueno, para no quitarles más su tiempo, yo quisiera en primer lugar agradecer. ¿Me puedes escuchar bien, Marco?
I can hear you, Diego. Yes, good night, good evening from Austria.
Buenos días aquí en México. Bueno, yo quiero presentarles, antes de iniciar, yo quisiera presentarles al doctor Marco Corchaque. Marco es profesor de tiempo completo de la Universidad de Innsbruck en Austria. Es vicepresidente del Instituto de Anatomía Clínica y Funcional, experto en anatomía aplicada, funcional, clínica y quirúrgica, así también como en educación. Cuenta con más de 50 trabajos de investigación publicados, entre los que destacan artículos de revisión, trabajos originales y capítulos en libros y revistas nacionales e internacionales. El día de hoy presenta la conferencia magistral titulada Anatomía Clínica del siglo XXI, de las mesas de trabajo a la cama del paciente y de vuelta, nuevas estrategias. La Sociedad Mexicana de Anatomía le agradece su participación, nos da en verdad muchísimo gusto y esperemos que el año que viene te podamos tener en México.
Thank you very much. I think it's my turn, right? Okay, good evening from Austria all together. I'm trying to show you my presentation. So once again, good evening from Austria and good morning to Mexico. First of all, thank you very much for this nice invitation to having this talk in your conference. Thank you very much to Professor Martinez and all his colleagues for this invitation. It's I appreciate and thank you very much for this. So
Marco, please wait a minute.
Okay. Okay, then cheers. Cheers.
Ready, Marco.
Okay. Okay, so this is my disclosure, and I've got some minutes. And as I said, I really appreciate to talk to you. And first of all, please let me introduce myself. My name is Marco Corchaque, and as Diego already said, I'm the head of the Institute of Clinical and Functional Anatomy here in Innsbruck, a specialist for clinical and applied anatomy, and I'm also the member in the ISCA Society, our International Society of Clinical and Functional Anatomy. I'm talking to you from Austria, especially from Innsbruck. And I just want to show you where I'm talking from to you. I'm sitting here in my office in Innsbruck. It's in the middle of Europe, in the heart of the Alps. And I'm talking to you over the ocean to Mexico. And this is my city where I'm working, in the middle of Europe, in the middle of Austria, in the heart of the Alps. It's called Innsbruck. Here it is. This is our city. This is Innsbruck by night. And this is our university. Here is from daylight, during the daylight. This is my university where I'm working the whole day. This is our institute, the Institute of Clinical and Functional Anatomy. It's a very old building, and it was built up already in 1885. So it's a really old building, but we get renovations just a few years ago. Innsbruck is also very famous. Again, I have to talk about my city I love very much. We have a lot of snow in the winter. And this is a picture of mine. I also like skiing very much. This is me skiing in the mountains. It's just 5 minutes from the city to go into the mountains where we can do skiing all the time. So just for a short introduction of our nice city. So hello to Mexico from Austria. So please let me talk about the challenges of clinical anatomy in the 21st century. What are the challenges for us, especially for the clinical anatomists? The first thing is we have to start, as always, with clinical questions. What are there clinical questions? The second thing is when we have the clinical questions, we try to solve these problems with the clinicians together, doing clinical anatomical research and evaluation. Important for us, when we did the anatomical research, when we have our results, it's important for us to do under and postgraduate education, as you see here myself doing ultrasonography with students here in our institute. And also what's important for us is to work together with the clinicians here, for example, with surgeons, that's me. I'm going to the operating room with them quite often every day to work with them on the patient and to solve anatomical or clinical questions. And of course, this is the most important thing, not only to solve clinical questions for a clinical application, also the way back from the patient to us, to the anatomical department, to the anatomical research is also very important. So when we are talking about anatomical research, especially clinical anatomical research, I want to give you now some examples what we are doing here in our institute, and I will give you some examples of our newest publications of our works. The first thing is we are working on body donors. We have a body donation system, so we have to talk about translational anatomy on body donors. The second thing is I will show you some translational research, what we did here in our institute, especially in my group about peripheral nerves. I will show you some results, what we did in plastic, endocrine, general, or in neurosurgery. So the first question was, it was a long a few long years ago with a colleague of mine, Eric Brenner, was already published in 2014, but it is at the moment also a very interesting and very important publication, because we thought about what we are doing here in our institute on our body donors. Is this a representative for the population, what we are doing on our body donors? What are the causes of death, for example, etc.? So the background of this study was to show if our work on body donors is representative of the population, especially on the Austrian population, and is there a validity of our translational anatomic science and education for our students. What we did is we did a retrospective evaluation of around 3,400 body donors of the last 25 years. So from 1988 to 2013. And we did a categorization of the causes of death according to the ICD-10 WHO classification, and did a comparison from our data with the data of the statistic group of Austria and the so-called Statistischen Bundesamt. This is the statistic group from Germany. And the first question was, as I said, what are the causes of death of our body donors? Because we often get some quite difficult questions from outside. Are you doing your work on body donors which are not representative with the population? And this is the answer for us. As you can see here, we did retrospectively evaluating 3,400 body donors. And what do you think? The most important disease, the most important cause of death, as you can see here, are the diseases of cardiovascular system. The first, only 20 to 25% are dying to cancer. So the most body donors die on cardiovascular system disease, cerebrovascular disease, hypertension, heart disease, etc., etc. So, or here, the cancers, for example, the most important, the lung cancers, as you can see here, bowel and breast cancers are also very representative here. We did also have a look on the gender distribution. And as you can see, it's quite the same on cancer and disease of the respiratory system. But if you have a look on psychiatric disease or infectious disease, there are more women dying on such causes. So once again, just approximately half of our body donors, they die on a disease of the circulatory system. So what is the important thing of that? They do not have morphological pathologies a lot. Cancers as neoplasm, they have 20%. In Germany, as you can see here, is quite the same, 40% and 25%. What is the conclusion of such data as what we get from this study? We see that we have no differences between the data of our body donors we have in our institute and the data outside. Outside, I mean from the other statistical groups from Austria and Germany. So these data for our research are representative, and therefore they are also valid for our translational research and science. So, as I said before, this was a very important publication to highlight our anatomical clinical research, to search for a clinical topic, do anatomic enlightenment on our body donors for a possible clinical application for our patients. Second thing, as you can see here, this is our biggest hall for our main lectures with our students. It is unfortunately some years ago, because as you can see here, no masks. It was the time before the Corona pandemic. So unfortunately, they are sitting there without having any masks, etc. These pictures we don't have at the moment, unfortunately. So please let me give you some, or show you new results of our research on peripheral nerves. The first research I wanted to show you is a paper we published for plastic surgeons, and we did with plastic surgeons. As maybe everybody from Reunión know, is that migraine headache is a very important part of neurology and very important for patients. And what we did is that we thought that there is a peripheral pathomechanism for the so-called frontal migraine headache due to compressions of peripheral nerves. In this study, we highlighted the craniofacial nerves, the supraorbital nerve and the supratracheal nerve. And what we did with our plastic group is that they saw that, or that they have patients with migraine headache, and when they did a Botox injection into muscles, that the muscle leaves the compression and decompressed the nerves. So we thought that a so-called trigger site decompression surgery, a small surgery on the muscle where the nerve pierces the muscle, might ameliorate frontal migraine headache symptoms. So what we wanted to do is to have a look on the supraorbital region, because it's one of the most important headaches for migraine patients. We used different anatomic techniques. First of all, macroscopic dissection of 22 hemifaces. We also wanted, or we also did an ultrasonographic performance on probons for a possible step-by-step approach for a clinical application. These are our first results from the macroscopic dissection. As you can see here, this is the corrugata supercilii muscle. It's a very important muscle because the supraorbital nerve and the supratracheal nerve regularly are piercing this muscle. On the right side, here in red or orange, this is this corrugata supercilii muscle. On the left side, this is the supraorbital nerve and the supratracheal nerve, the piercing points of these muscles through, of this nerve nerves through the corrugata supercilii muscle. Please have a look on the specimen here. This is a very nice dissection. It's a dissection from me from behind. It is a mask. We did the dissection from dorsal. It's a dorsal view. It's a so-called mask preparation. We did it from dorsal to see all the mimic muscles from dorsal and to evaluate the piercings of the nerves. Here the view from outside. You see the foramen or the incisura on the frontal bone, and you see here the nerves coming out from this incisor and piercing the corrugata supercilii muscle. Also here on the right side, not every ramus is here piercing the muscle, but there are almost often branches piercing the muscle. The next interesting result was, of course, as clinical anatomists, we know this that peripheral nerves also are going with arteries together. And therefore, it is also possible that the pulsation of arteries could affect peripheral nerves due to the pulsation process. And as you can see here, it is possible that nerves go over or lying deep to arteries. Here on the right side, you see the possible courses of the artery to the nerve. And on the left side on the specimens, we also evaluated the height and the length of the incisura or the foramen in the frontal bone, as you can, for a possible entrapment spot. You can see it here. It's differing from 3 to 15 millimeters. So what we did with these results, we also tried with a high frequency ultrasonography to perform a preoperative ultrasound on the patient to have a look if it is possible to see the muscles and these small nerves on ultrasonography, and to create a so-called step-by-step approach, as you can see here on the right side, for daily practice. And as you can see here, it is possible. It was possible with a 20 megahertz ultrasound probe. It is possible to visualize such small nerves and the muscles, also to visualize the piercing of such nerves through the muscles. And the step-by-step approach is this what the clinicians want from us. They come here in our institute, we show them what they have to do, we learn them what they can do, and to, in this example, how to visualize such nerves and muscles. So the possible trigger sites for these nerves, for the supraorbital nerves, what we found here in this study was the osteofibrous tubes, as I showed you before, the muscle, especially the corrugata supercilii muscle, also the septum, the orbital septum, because the supratrochlear nerve is piercing the septum, and also the topographic relation to the supraorbital artery. Excuse me. So what is the conclusion? What is the clinical consequence of this study? Our preoperative ultrasound performance of such small peripheral nerves also the mimic muscles, of course, is possible also with a practical approach. The trigger site decompression surgery for selected drug-resistant patients with frontal migraine headache is an important factor for amelioration of the symptoms evidenced by our work, evidenced by our body donors, evidenced by the anatomy. At the moment, we have already done some patients with our plastical department, and I must say that we have very nice results already on our patients with drug-resistant frontal migraine headaches. And this is for me the best thing what we can do when I can see that our clinical anatomical research, we can immediately help our patients. Second paper, what I want to show you, second example, new results in endocrine surgery. As I already told you, I also worked a few years in the clinical departments, especially at the general departments, and especially on the endocrine surgery department here in our university clinic. And I was always interested in laryngeal nerves. So what we thought there, I got some impressions from the first operations, what we did there. And what I wanted to do is to have a look on the recurrent or inferior laryngeal nerve palsy, because as you know, this nerve palsy of the laryngeal nerve is one of the most severe complications in thyroid or parathyroid surgery or neck surgeries. And there is an important anatomic variation, the so-called non-recurrent inferior laryngeal nerve. This is the most important anatomic variation during thyroid surgery. And what we also did is we used, because I'm also working a lot with companies, with companies which have medical devices, and we used the so-called intraoperative neuromonitoring device as an important device. And we also did again, as in the study before, a preoperative ultrasonography, also to show as a diagnostic tool for ruling out a non-recurrent inferior laryngeal nerve pre-operatively, before the operation. This was our publication, the non-recurrent laryngeal nerve, a clinical anatomic mapping with regard to intraoperative neuromonitoring. This is actually a very nice publication. We could publicate it in the journal Surgery. It's a very high impacted surgical journal. And we used 36 specimens for a macroscopic dissection of the inferior laryngeal nerve. As said, we had the application of the neuromonitoring device, and we did a preoperative ultrasound application. Why? We wanted to show the representation of the brachiocephalic trunk as a so-called knockout criterion for a non-recurrent inferior laryngeal nerve. And we showed, or we did a step-by-step algorithm for our clinical colleagues. These have been the anatomical dissection. Please have a look on this specimen. During our dissection courses, this is a specimen we dissected during our dissection courses. Please have a look on this anatomical variant on the left side. You can see here the vagus nerve. This is the vagus nerve. This is the common carotid artery. This is the vertebral artery. And normally you can see, once again, you can see also here an artery running close to the trachea and the esophagus, but lying dorsally to the esophagus. This is the so-called lusorial artery, arteria lusoria, arteria dysphagia lusoria. And as you can see here, there is a nerve running, not around this artery. There is the course of this nerve running directly to the thyroid gland and to the larynx. So there is one important arteria missing here on this picture, is the brachiocephalic trunk. It's missing. Also on the right side. This is on the left side, this is the so-called ascendant non-recurrent inferior laryngeal nerve and ascendant nerve. Here on the right side, another specimen with a transverse course of this nerve. Why is this surgically important? Another specimen here on the left side. During such operations on the neck, we use neuromonitoring systems. With such systems, you can stimulate the vagus nerve. With the stimulation of the vagus nerve, you can stimulate also the laryngeal nerve and the vocal fold of the patient. And then you get here on the right side, during the operation, a signal showing you that all the nerves are okay. The problem is when you stimulate the vagus nerve caudally of such an anatomical variant, it's not possible to get any signal. So it's very important. And after our publication, we get a lot of answers from colleagues. They called us and told us that such, especially the ascendant version, the ascendant variant is very frequent because normally you did not see such variant during the operation. This is the operating situs. And just for example, on the left side, this is a descendant variant of such a nerve running tightly, quite directly next to the thyroid gland, to the upper pole of the thyroid gland. And with the stimulating probe, we stimulate the nerve and you get the signal. We also tried to do for the intraoperative neuromonitoring an algorithm for our surgical friends. As you can see here, it shows what they have to do during the operation if they get no vagal signal. They have to stimulate the contralateral vagus, and so they get a positive or a negative signal, and they have to go through this algorithm to find such anatomical variants. Also very important was that we could show the recurrent laryngeal nerve around the brachiocephalic trunk. And as I showed you before, it's very easy when you understand embryology. If there is no brachiocephalic trunk in a patient, it's when you are a little bit used to ultrasonography, it's just a little work of a few minutes. to visualize a brachiocephalic trunk. And if a brachiocephalic trunk is missing in a patient, there has to be a variant of a laryngeal nerve, a descending, horizontal, or ascending. So what in our university clinic, the surgeons, the endocrine surgeons now are doing, every patient is becoming an ultrasonography a few minutes before ultrasonography to visualize the brachiocephalic trunk and to rule out such anatomical variants. So the conclusion of this study is the preoperative ultrasound application with the representation of a brachiocephalic trunk is an exclusion criterion for anatomical variants, such a non-recurrent, and it is possible to have a step-by-step algorithm. Also, this neuromonitoring device is a reliable device for exclusion of such anatomical variants. A next example, it's an example we did with the orthopedic surgeons. It's an example about the so-called Baxter nerve. It's a small, tiny nerve in the foot. Everybody of you know maybe the so-called heel pain syndrome. And a neuropathy of the Baxter nerve, normally it's the first cause of such a heel pain syndrome. Heel pain syndrome is a common foot problem in athletes, especially when they do running or if they do jumping, etc. They are coming to the orthopedic clinic. What we did is we tried to find this Baxter nerve and to do minimally invasive procedures, ultrasound guided at the ankle for a foot decompression surgery at the tarsal tunnels. So also in this study, we did macroscopic dissection of 41 alkyl-glycerin embalmed specimens. We did a documentation of the patterns of the branches of the tibial nerve and describing all the relevant osteofibrous structures. We did a measurement of the so-called McDillan malleolar calcar line for the proximal tarsal tunnel and the so-called Heimke's triangle for the distal tarsal tunnel. This malleolar calcar line and the Heimke's triangle are or have been already described before our study, but these are very good anatomical landmarks for visualizing such small nerves. And also what we did is we tried to do an ultrasound guided insection procedure for a possible insection of the Baxter nerve. And also again, as you can see from the other works, to provide an algorithm for clinical daily usage. This is our region where we did our macroscopic dissection. You see the green line. The green line is the so-called Dallon-McKinnon line from A1. It's the medial malleolus to the center of the malleolus. And this black triangle is the so-called Heimke's triangle, where, as I told you before, you can find as a typical anatomical landmark to find these nerves. What we did is first our macroscopic dissections, very nice dissections of the different tubes of these small nerves. And as you can see here, this is the so-called Baxter nerve. This is the important nerve for a heel pain syndrome, running through such small tubes to the calcaneus. This is the ultrasound picture. This is the tibial nerve. Here you can see the posterior tibial artery with the both veins, the posterior tibial veins, the tibial nerve, and the flexor hallucis longus muscle just for orientation. And from the next picture, we were able to visualize the Baxter nerve here as this small nerve running just next to the vessels, deep to the structures here to the calcaneus and the quadratus plantae muscles. On the right side, this is the typical projection. You see here this gray castle here to this should be the transducer, and you see here the Baxter nerve running through his tube down to the calcaneus and to the plantar pedis. And on the left side again, it was possible to show this nerve with ultrasonography. We did again a step-by-step approach for our clinical colleagues. We show them how you can find and inject these small nerves. We did the proof on our body donors with diluted colored latex using ultrasonography. And as you can see here, exactly, it's a very nice injection proof where we diluted our latex around the nerve. And this was our result for the entrapment spots to show the orthopedics and plastic surgeons where they can find the nerves using the triangle, the Heimke's triangles for the classical entrapment spots for the Baxter nerve, also for the medial calcaneal branch and the medial branch of the medial plantar nerve. These are the typical entrapment spots of the nerves where the patients have the typical symptoms when they come into the clinics. So what are the clinical consequences of this study? We could show that this detailed mapping of the tibial nerve branches and also of their tubes at the tarsal tunnels have an importance for foot and ankle surgeons, for minimally invasive procedures, such as ultrasound-guided ankle and foot decompression surgery. And my last paper I wanted to show you is what we recently published with my friend and mentor with our group, José Sañudo, and our PhD student, now Dr. Sara Quiñones, and our other colleagues also from Madrid and here from Innsbruck, and also Professor Tubbs from USA. It's a very nice study, really very nice study. What we did, the aim was to study the origin of another nerve. It's the so-called sinovertebral nerve, the course and the distribution. And what we did here in Innsbruck is also an immunohistochemical characterization of the fibers of the nerve. So what we did in this study is we did a dissection of the nerves in 6 spine blocks, and we did a CGRP and a VIP IHC characterization of the nerves. As you can see here, very nice dissection they did in Madrid at the Complutense University. You can see here the sinovertebral nerve coming here from the ramus communicans, and here is the trunk coming down here for an innervation of the discs and the ligaments. Also here, very nice dissections from dorsally, and here the view to ventral on the right side. Here the pedicles, just for orientations, the venous plexus, everything was removed to dissect such small nerves. These here showing with an arrow, these are the small sinovertebral nerves. From fresh cadavers, we get these nerves for our laboratory, and we did CGRP and VIP immunocharacterizations of the nerve. 48 levels we did the characterizations. And what we found is that the sinovertebral nerve has 100% double origin from the spinal and from the sympathetic trunk. We saw that they have, in comparison with other literature, we have different courses of the nerve, ascendant, descendant, connections on the same side. So, but we do not find collateral connections, only ipsilateral connections in 12 of the 43 cases. The immunohistochemistry showed also positive signals for CGRPs and also positive signals for VIPs of the specimens evaluated in our laboratory. So the conclusion of this study was that the results of this study suggest a general pattern of the sinovertebral nerve having two different routes, a spinal and a sympathetic route, and an initial recurrent course entering into the vertebral canal close to the vertebral notch of the pedicle. This nerve can follow different courses, as showed before, ascending, mixed course dividing into two branches, or a descending course. The branches ended deep to the posterior ligament, and the branches of the sinovertebral nerve have ipsilateral connections and do not cross the midline. The nerve has positive fibers, CGRP positive and VIP positive fibers, CGRP fibers associated with nociception transmission, as you know, and VIP positive fibers related to autonomic system positive fibers. And the last, and the last slide, or the last paper project, what we have is also a very nice project we have with another university from Germany, with general and urologic surgeons. We are the so-called Neuro-NB project with neuromonitoring for patients who have rectum cancer. And as you know, that when you have patients with rectum surgery, a lot of people have problems after the surgery with the mixture. So we tried to do on pigs. We evaluated the autonomic plexus of the pelvis on 12 pigs using the neuromonitoring system, and also we did an immunohistochemistry evaluation of the nerves of the autonomic pelvis to find out which nerves, which fiber quality are in these nerves in the deep pelvis. This is a project which was funded or is funded by the German Ministry of Health, and we are working now also on this project. So all in all, what is translational applied anatomy for me in the 21st century? For me, it means educating and researching on representative samples of the general population, to address or addressing under-investigated anatomic details, substantiating empirical therapeutic approaches, increasing individualized surgery, to optimize surgical procedures. So, actually, fear of surgery is not knowing anatomy. I always go to my surgical friends and have fear of surgery. You just have to learn anatomy, and that's all. Of course, it's not all, but it's a nice claim for clinical anatomy. My friends, I want to say thank you to my mentor and friend, Jose. I hope he's looking and he's watching us. Jose, thank you very much for your help and all your ideas. I like very much working with you. Many thanks, Jose. I hope we can see us personally in the next few months. Thank you very much for your attention. Gracias por su atención. Thank you very much.
Claro que sí, Marco. Te agradezco nuevamente el haber aceptado dar esta charla. Creo que mucha de la gente que nos sigue en la Sociedad Mexicana de Anatomía son estudiantes. Y esos estudiantes muchas veces están interesados en hacer investigación. Y creo que les acabas de demostrar hacia dónde tienen que dirigir sus investigaciones y cómo se deben hacer las investigaciones. Una investigación que no tenga aplicación clínica difícilmente va a ser bien valorada y bueno, pues creo que además nuestra función es brindarle a todos aquellos que son quirúrgicos una seguridad al estudiar variantes anatómicas. Así que aplaudo todo lo que tú haces. Desde aquí seguimos tu trabajo, sabemos lo que trabajas, las líneas de investigación que tienes y esperemos pronto poder colaborar contigo. Te agradezco mucho y vamos a iniciar con las preguntas. Me parece que Daniel Rosales tiene una pregunta.
Hola, doctor. Muchas felicidades por tan excelente plática. Mi pregunta va relacionada hacia qué pacientes o en qué circunstancias realizar algún método de tamizaje para valorar la presencia de variantes anatómicas, sobre todo nerviosas y vasculares. Gracias, doctor.
Yeah. This is the point is that there are no special candidates. You do not know it before. You don't know if the patient has such anatomical variants. This is why we try to give the surgeons algorithms to find, to have a look for such anatomical variants pre-operatively. There, for example, my study for the laryngeal nerves, there is no, you cannot know it before, but as we know that the laryngeal nerve palsy has been a very bad complication for this surgery, and that's why we started this study, and we were searching for such nerves. So actually it's a little bit luck if you have a patient with such an anatomical variant. Yeah. Was this your question?
Sí, doctor, muchísimas gracias.
Me parece que ahí Daniel, Jessica González, doctora, tiene la palabra.
Hola, muy buenos días, Marco. Muchísimo gusto, excelente plática, gusto en verte de nuevo. Me llamó la atención cuando hablaste de las causas de muerte de los donantes de tu universidad. Me gustaría ahondar un poquito más y saber si tienen muchas causas infecciosas, tipo sepsis, shock séptico, y si las tienen, si eso les afecta en algo el proceso de embalsamado.
Jessica, as you know, you watched my talk very nice. Thank you. Because actually you are right. Actually, we do not accept body donors having a sepsis. Actually, but sometimes we get such body donors to our department. The problem is, and that's why I always say to my assistant, please have a look that they do not have any infections or diseases like that, because the embalming process is very bad. Yeah. Okay.
Sí. Sí, lo hemos notado, nos pasa en Costa Rica con procesos de shock séptico. El proceso de embalsamado hemos visto que no es el ideal. Entonces, muchas gracias.
Me parece, por ahí tengo otra mano levantada. Tenía otra mano levantada de Sergio Jiménez.
Doctor, muchas felicidades, excelente plática y qué oportunidad de poder relacionar la anatomía con la clínica y ver su utilidad y practicidad en algo que vemos diario, ¿no? En el hospital. Me gustaría preguntarle, ¿hay alguna predisposición con respecto al sexo de los donantes para encontrar estas variantes anatómicas? Muchas gracias.
Yeah. Yes, we have the data, but I don't know which study you mean, but we have the data for the sex classifications, but we did not had published it yet. But we have the data to evaluate the sex differences. We have it, but you are right, we have not published it yet. You are right.
De acuerdo, doctor, pues esperaremos para poder observarlos e identificar esta predisposición que exista. Muchas gracias.
Si alguien más quiere participar, por favor puede prender su micrófono. En este momento estamos revisando también nuestras redes sociales a ver si hay alguna pregunta en las redes sociales. Un par de minutos nada más para asegurarnos que no haya ninguna pregunta en las redes. Bueno, lo que vemos en las redes son muchas felicitaciones por su ponencia, así que yo me uno a esas felicitaciones y a nombre de la Sociedad Mexicana de Anatomía agradecemos muchísimo haber contado con tu presencia, Marco. Esperamos pronto, además de tenerte en México, poder colaborar con otros proyectos. Pues conocemos perfectamente al doctor Sañudo y creo que podemos hacer muy buenos vínculos.
Yes, I hope so too, Diego. Maybe next year I will come to Mexico. I've never been there, so it would be a pleasure to visit you there. And to all students listening to us, we are happy to collaborate with everybody. So just write me. I'm happy to do so. Thank you very much, Diego. Thank you.
Marco, perdón, abusando, sé que ya te había despedido, pero Tengo dos preguntas más que creo que son muy importantes. Una, los estudiantes me están diciendo si tú en tu laboratorio tienes posibilidad de aceptar alumnos mexicanos.
I think so, yes. I think there is no problem with the Erasmus program. Do you know the Erasmus program? Yes.
Sí.
Yeah. So I do not think that this is a problem. So if there are possibilities to make a change, just write me. I will have a look to do so with our rector. It's no problem. I will have a look.
Perfecto. Y aprovechando tu presencia, veo una pregunta también importante. Nos dicen, ¿qué recomendación podría brindar a los alumnos para iniciar investigación y combinar la clínica con la anatomía de la forma que tú lo has realizado?
Yeah. Yeah. Thank you. Also very good questions, because this is a problem for our young investigators to get the clinical topics for their anatomical research. This is why we did on our university the so-called clinical PhD. Oh, everybody knows the PhD program. We on our university, we started the program so-called clinical PhD. And this is for young investigators also working at the university or in our department, working together, solving clinical questions. This is the first thing what they can do. The second thing is, if someone is interested to working in anatomy, in an anatomical department, I always tell them, please go to the clinicians or go to a clinical department and work there for a few months or for a few years, and then work together with the anatomical department. So for me, it's very important to also, you know, I think it's sometimes it's a problem to work on clinical anatomical research if you do not have seen any patient personally. Because you have to understand the problem, you have to understand the work of the clinicians. Yeah, you have to understand. You have to understand also the problem there, not only in the anatomical departments. Also you have to understand the work of the clinicians and their problems.
Muy bien, muchas gracias. La doctora Lorena Valencia, que está aquí a mi lado, ella es tesorera de la Sociedad Mexicana de Anatomía, tiene una pregunta para Marco.
Doctor Marco, ¿hay algún convenio de colaboración entre la universidad y las instituciones médicas, llámese hospitales principalmente, o algunos centros de imagenología que puedan compartir sus bases de datos de los pacientes que han hecho resonancia magnética, ultrasonido rayos X, y que desde la universidad se pueda tener acceso a esa base de datos para desarrollar investigación?
This is a very good idea. Thank you very much for that. But we do not have very good. Thank you. This is a very good idea. I have to think about this. I think this would be very fruitful for our clinicians to have a database where we can make an exchange for such things. We do not have, but it's an excellent idea. Thank you very much for that.
Muchísimas. Sí, por favor.
Sí, doctor. Ojalá y pueda llevarse a cabo esta colaboración. Hace algunos años atrás, la Universidad de Granada, en España, firmó un convenio de colaboración con el clínico de ahí también, de esta ciudad de Granada. Nosotros desde el ámbito de la antropología física y forense, tuvimos acceso a esa base de datos de los pacientes. Y le puedo comentar y compartir que a la fecha de ahí han surgido muchísimas tesis doctorales y mucha información que aporta para el ámbito de la identificación humana desde la antropología forense. Entonces, ojalá y logre establecer el vínculo entre la universidad y los hospitales o los centros de imagenología. Felicidades por su charla. Gracias.
Yes. Thank you very much also from my side, and maybe I can contact you for your great idea. I will come back to you soon.
Bueno, pues ahora sí, nuevamente muchas gracias, y creo que con esta plática también nos llevamos una reflexión. Aprovecho que estamos reunidos muchos morfólogos, porque gracias a esta plática y a muchas que han pasado durante esta semana de congreso, podemos decir que es muy importante la relación que hay entre el morfólogo y el clínico. Es tan importante tener el morfólogo tener a un clínico como el clínico tener a un morfólogo. Y creo que a veces trabajamos separados y eso es lo que no nos lleva al éxito. El éxito está cuando sumamos esfuerzos. Así que muchísimas gracias por darnos este panorama.
Thank you very much. You too. And good morning to Mexico.
Gracias.
Chao.
Muchas gracias.
Gracias.
Bye.
Gracias. Bye bye. Gracias.
Bueno, pues para continuar con las actividades de la clausura del Congreso, yo quisiera pedirles, porque ya tenemos programado, y lo tenemos programado a las 12, muchas universidades que quieren estar presentes porque se va a hacer mención de su primer lugar o su segundo o su tercer lugar, me han pedido que se van a conectar una vez dando las 12. Por respeto a ellos, creo que vamos a respetar el programa académico. Nos vamos a quedar, bueno, les vamos a dar un tiempo para que vayan a tomar un café y regresamos. Vamos a dejar micrófonos apagados, vamos a dejarles proyectando un video y nos volvemos a encender cámaras y micrófonos en punto de las 12. Nos vemos ahorita para la clausura.
Dime, Lucía. No podemos aplazarlo mañana, cariño. Joder. Es que estoy muy cansado. Mañana. Y de noche me da no sé qué conducir. Ya sé que te lo he dicho.